If you've ever had a cut, scraped a knee, or even just, stop to think about what happens inside your body after something major like a heart attack or maybe some kind of toxic exposure, you're looking right at the body's absolute drive to survive.
Yeah, and that drive really comes down to repair. When trauma hits, doesn't matter if it's a physical wound, a deep infection, or maybe chronic damage from toxins, our immediate survival and really our long-term function, it all hangs on how well the body can patch things up, put itself back together.
But it's not like the body has just one single plan for recovery, right? There's this fundamental choice it makes, this kind of big split we want to unpack today. Plan A, you could say, is the dream scenario, regeneration.
Exactly. That's when the damaged tissue gets perfectly replaced. It goes right back to its normal structure, normal function, like nothing ever happened.
But Plan A seems pretty rare, reserved for maybe minor scrapes or specific tissues.
That's generally true. Most of the time, particularly if the damage is really bad, the body has to go with Plan B, repair, by connective tissue deposition.
Which is the clinical term for what most of us just call a scar formation. And our mission in this deep dive is really to follow the steps, this complex sequence the body uses to build that patch, understand how it's controlled, and maybe more importantly, why that patch can sometimes cause problems down the line.
And here's something to think about, maybe the initial shock factor for you listening. We tend to think of a scar as, just a cosmetic thing on our skin. But that exact same basic biological process making and stabilizing fibrous collagen is what's behind some really debilitating, even life-threatening conditions inside the body.
Like what?
Well, think about severe lung fibrosis or end-stage liver failure or even chronic heart problems after a heart attack. It's all driven by the same fundamental scarring mechanism. It's universal, and when it gets out of control, it can be really dangerous.
Okay, so let's start with the basics. We use terms like healing and repair. Are they basically the same thing in this context?
Yeah, for what we're talking about today, they're largely interchangeable. Both refer to restoring the tissue structure and function after it's been injured. Historically, healing might have been used more for skin surfaces, the epithelia, and repair, maybe more for deeper tissues like organs or connective tissue. But really, the goal is identical. Fix the damage.
Right. So the big question then is, why does the body, which can do these incredible things, often just settle for a patch, the scar, instead of always going for perfect regeneration?
It really boils down to two major limitations. Things that make scar formation, that laying down of dense fibrous tissue, pretty much inevitable if either one is present.
Okay, limitation number one.
Condition one is simply that the cells themselves can't be replaced. If the injured tissue is made of cells that just don't have the ability to divide and regenerate anymore, we call those permanent tissues.
Ah, like brain cells.
Yeah.
Or heart muscle.
Exactly. Mature neurons in your brain, or those cardiac muscle cells, the myocytes. Once they die, they're essentially gone for good. The body just doesn't have the instructions to rebuild them from scratch.
So they trade their ability to divide for being highly specialized. That heart cell is amazing at pumping, but it can't make copies of itself.
Precisely. And the second big reason scarring happens is maybe a bit more subtle. Even if the cells could divide, take liver cells, for example, they can regenerate. They absolutely need their structural support system, the extracellular matrix, or ECM. They need that scaffolding to be intact.
The ECM, that's like the framework that tissue is built on.
Exactly. If that ECM is too badly damaged, if the whole framework collapses, well, then the cells that are trying to regenerate just lose their way. They don't have the guideposts.
So without the ECM, the new cells don't know where to go or how to organize or even what shape the organ should be.
That's a huge part of it. The ECM isn't just physical support. It gives off chemical signals, mechanical cues. It guides the whole regeneration process. So if it's destroyed, say, by a really bad infection or widespread tissue death, necrosis, the body just can't wait around hoping for perfect regrowth. It has to plug that hole, stabilize things now. And that means building a patch.
Okay, makes sense. It's a necessary compromise. Now, you mentioned pathologists use different terms for this patch depending on where it is. Can we clarify those?
Sure. There are three main terms, but remember, they all describe the same basic process: laying down collagen fibers. The most common one is probably scar. We usually use that when talking about wound healing in the skin. It's that mature fibrous area you can see.
Okay, scar for skin. Then there's fibrosis.
Right. Fibrosis is the technical term we use when there's excessive collagen being deposited usually chronically, inside an organ, like the lungs, liver, kidneys. It often happens slowly, kind of creeping up as a result of long-term persistent inflammation.
So like the damage in the heart muscle after a heart attack, that would be fibrosis.
That's a perfect example, myocardial fibrosis. Or think about liver cirrhosis, those thick bands of collagen choking the liver. That's fibrosis.
And the third one you mentioned sounds a bit counterintuitive. Organization.
Yeah, it does
Yeah.
sound kind of positive, doesn't it? Organization refers to a specific situation. It's when fibrosis, or scarring, develops in a space that used to be filled with inflammatory gunk, what we call exudate, like pus or fluid from inflammation. If the body can't clear that inflammatory material out completely, it basically walls it off with fibrous tissue. It organizes the mess into a permanent scar.
Like organizing pneumonia.
Exactly. That's a classic example where inflammation in the air spaces gets replaced by fibrous tissue.
So whether we call it a scar, fibrosis, or organization, it's still fundamentally that dense collagen patch. It doesn't do the job of the original tissue like contracting muscle or filtering blood, but you're saying it's still necessary.
Absolutely necessary. It's the ultimate trade-off. The body chooses stability over specialized function. That fibrous scar holds the damaged tissue together, prevents it from just falling apart, and allows the organ or structure to keep going, even if it's not working perfectly. It might be flawed, but from a survival standpoint, it's often essential. To really get what a scar is, you need to see the process. It's not just dumping collagen. It's this incredibly dynamic, carefully orchestrated sequence. It involves lots of different cell types, signaling molecules, like a biological play with multiple acts. And it generally follows a predictable order: hemostasis, inflammation, cell proliferation, granulation, tissue formation, connective tissue deposition, and finally, remodeling.
Wow, okay. A 6-step process. Let's walk through it, stage by stage. Where does it all begin right after the injury?
Okay, the very first response, happening within minutes, is hemostasis. That's stopping the bleeding. It's driven by platelets activating and the whole coagulation cascade kicking in. You form a plug made of platelets and fibrin.
Right, got to stop the bleeding first.
Absolutely. But that plug does more than just stop blood loss. It also acts as the initial scaffold. It's the first temporary matrix laid down, providing some structure. And crucially, it releases a whole bunch of growth factors and chemical signals, what we call chemotactic agents.
So that clot is like sending out a distress signal, calling in the repair crews.
That's a great way to put it. These chemical signals, released by the activated platelets and also from the complement system breaking down, they call in the first responders, the neutrophils. They swarm the area in the first 6 to 48 hours.
The cleanup crew.
The initial shock troops, yeah. Their main job is to kill any microbes that got in and start clearing away the immediate debris, dead cells, damaged tissue. Then, over the next day or two, they get replaced by a different cell type, monocytes, which then mature into macrophages right there in the tissue. This whole first phase is about neutralizing threats and clearing the site so that rebuilding can actually begin.
Okay, so the initial mess is being cleaned up. What happens next as the really intense inflammation starts to die down? The focus shifts to building.
Exactly. Now you see rapid division, proliferation, and movement migration of several key cell types. It happens on two main fronts.
Two fronts, yeah.
Now, on the surface, if it's like a skin wound, you have the epithelial cells. They respond to local growth factors and start migrating across the wound bed, trying to cover the gap quickly. That restores the barrier.
Okay, patching the surface. What about underneath?
Underneath, you've got the fibroblasts. They start dividing rapidly and moving into that fibrin clot, that initial scaffold we talked about. They are the main construction workers, the cells that are going to eventually produce the collagen that forms the bulk of the scar. They're getting into position.
Right, so we have the surface being covered and the builders, the fibroblasts arriving underneath. But surely they need supplies, like oxygen and nutrients.
Absolutely critical point. Any new tissue construction needs a robust supply line. You need oxygen, you need nutrients for all this cell activity, and that's where angiogenesis comes in.
Angiogenesis, that's building new blood vessels.
Precisely. It's the process of sprouting new blood vessels, usually from ones that already exist nearby. Without angiogenesis, the whole repair process would just stall. The new tissue would die.
What triggers it? How do the existing vessels know to start sprouting?
Well, the main physical trigger is often just a lack of oxygen, ischemia in the damaged area. This triggers the release of chemical signals. A key early one is nitric oxide, which causes vasodilation, widening the existing vessels nearby to increase blood flow generally. But the real star player, the main signal for new vessel growth, is vascular endothelial growth factor, or VEGF.
VEGF. Okay, what does VEGF do specifically?
VEGF does a couple of crucial things. It makes the existing vessels more permeable, sort of leaky, which helps plasma proteins get out and form a provisional matrix. But its main job is to act like a powerful chemoattractant for the endothelial cells, the cells lining the blood vessels. It basically yells, hey, endothelial cells, start growing this way.
Okay, so VEGF points the way. But how does a stable, mature blood vessel actually, sprout a new branch? Walk us through that cascade.
It's a really elegant process. First, the existing vessel needs to be prepped. Cells called pericytes, which normally wrap around and stabilize capillaries, detach. And then enzymes called matrix metalloproteinases, or MMPs, get activated locally.
MMPs, we'll come back to those, I bet.
Oh yeah, they're crucial later too. But here, they break down the vessel's basement membrane, basically creating an escape route for the endothelial cells. Then, the endothelial cells themselves start to differentiate. Some become specialized tip cells.
Kip cells, like the leading edge.
Exactly. These tip cells extend long, finger-like projections called filopodia. They sense the VEGF gradient and migrate towards the signal. They don't divide much themselves. They're the scouts, finding the path.
The pioneers.
Right. And directly behind these migrating tip cells, you have the stalk cells. These are the endothelial cells that do proliferate rapidly. They divide and divide, providing the cellular material needed to lengthen the sprout and form the main body of the new vessel. They eventually form a hollow tube, the lumen.
Okay, so tip cells navigate, stalk cells build the length. But that sounds like it could get chaotic. If all the cells just started sprouting wildly, you'd end up with a tangled mess, right? How does the body control the spacing and branching?
Ah, excellent question. This involves another really important signaling system called the Notch pathway. Think of Notch signaling as the traffic director for angiogenesis. It ensures things don't get out of hand.
How does Notch act like a traffic cop?
So, as a tip cell moves forward, it expresses a specific protein on its surface, a Notch ligand. This ligand binds to Notch receptors on the endothelial cells immediately adjacent to it, the potential stalk cells. This binding sends a signal into the stalk cell that basically says, don't you become a tip cell too, stay put and proliferate.
Wow. So the leader cell actively suppresses its neighbors from also becoming leaders.
Precisely. It ensures that only one or maybe a few cells lead the sprout, preventing excessive branching and keeping the new vessel network relatively organized and efficient. Once the basic tube network is laid down, then other growth factors come into play, like PDGF and, importantly, TGFO again. These recruit pericytes and smooth muscle cells to wrap around the new tubes, stabilizing them, laying down a new basement membrane. This turns the fragile sprout into a more mature, functional capillary.
Okay, so we've got fibroblasts moving in, and this massive network of new capillaries being built through angiogenesis. The result of all this activity is something called granulation tissue. What does that actually look like?
Yeah, granulation tissue is really the hallmark of tissue repair, especially in wounds healing by secondary intention. You can see it grossly. It looks pink or reddish, soft, and kind of granular on the surface, which is where the name comes from. That's because of all the tiny new capillaries.
And under the microscope, what defines it histologically?
Histologically, it's characterized by those three things we've been talking about. Lots of proliferating fibroblasts, that dense network of new, thin-walled, often leaky capillaries from angiogenesis, and a loose, somewhat disorganized extracellular matrix being laid down by the fibroblasts. You'll often see inflammatory cells mixed in too, especially macrophages, still cleaning things up.
It sounds very active and temporary, like scaffolding.
Absolutely. It's a temporary, highly vascularized fill material. Its main job is just to fill the space left by the injury. And it's important to realize the amount of granulation tissue that forms is directly proportional to the size of the original defect. A tiny cut needs very little. A huge gaping wound needs a massive amount of this stuff to fill the hole before the real scar can form.
So granulation tissue fills the gap. But it's not the final scar, right? That comes from the next step, laying down the serious connective tissue. And you mentioned macrophages are key here. I thought they were just the cleanup crew.
Ah, this is where macrophages play their second, absolutely crucial role. They were the pivot point. They start out as what we call M1, or classically activated macrophages, the pro-inflammatory ones, focused on killing microbes and clearing debris. But then they undergo this remarkable switch. They transition to become M2, or alternatively activated macrophages.
Wait, the same cell type switches from being destructive to being constructive. How does that happen? Doesn't that risk confusion?
It's an amazing example of cellular plasticity. The switch from M1 to M2 is driven by changes in the local environment, particularly the signals they receive. As the initial inflammatory triggers fade and different cytokines and growth factors become dominant, the macrophages essentially change their programming. They stop releasing pro-inflammatory signals and start pumping out growth factors that stimulate repair.
So they put down the weapons and pick up the blueprints.
That's a perfect analogy. M2 macrophages are essential drivers of the next phase. They release factors that stimulate fibroblast proliferation and, critically, stimulate them to start synthesizing and depositing large amounts of collagen and other ECM components. They've gone from demolition crew to construction foreman.
And is there one particular signal that's really driving this construction phase?
Yes, if the M2 macrophage is the foreman, then the master signal, the main cytokine responsible for synthesizing and depositing all that connective tissue, is transforming growth factor beta, or TGF-beta.
TGF-beta. Okay, sounds important. Why is it considered the master regulator here?
Because it has powerful effects on multiple aspects of scar formation, all pushing towards building and stabilizing the matrix. It works on three main fronts.
Okay, front number one, pushing construction.
Exactly. TGF-beta directly stimulates fibroblasts to divide and migrate into the area. And most importantly, it cranks up their production of collagen, fibronectin, and other key ECM proteins. It pushes them into this highly synthetic state.
Okay, so it accelerates building. What's front number two?
It protects what's being built. TGF-beta actively decreases the breakdown of the ECM. It does this by inhibiting the activity of those MMPs, the matrix metalloproteinases we mentioned earlier, the enzymes that normally degrade collagen. So it's essentially saying build more and stop breaking down what we've already built.
Got it. Build faster, protect better. And the third front.
TGF-beta also acts as a potent anti-inflammatory cytokine. It helps to shut down the remaining inflammatory response, for example, by inhibiting lymphocyte activity. This is crucial for allowing the synthesis phase to really take over without ongoing destruction. It helps terminate the initial war phase.
So TGF-beta is pro-synthesis, anti-degradation, and anti-inflammation. It really covers all the bases for building that scar.
Absolutely. And as TGF-beta dominates and fibroblasts ramp up production, the tissue starts to mature. That highly vascular, pink, soupy granulation tissue gradually becomes less vascular, paler, and denser as more and more collagen accumulates.
You mentioned collagen. Is it all the same type?
Not initially. In the early rapid synthesis phase, fibroblasts tend to lay down a weaker, more provisional type of collagen, mostly type 3 collagen. But as the scar matures over weeks and months, this gets gradually replaced by the much stronger, more durable type I collagen. That's what gives the mature scar its tensile strength.
And you also mentioned some fibroblasts change into something called myofibroblasts.
Yes, that's another key part of maturation. Some of the fibroblasts within the granulation tissue start to acquire features of smooth muscle cells. They develop bundles of actin filaments inside them. These specialized cells are called myofibroblasts.
Myo meaning muscle-like. What's their job?
Their main job is contraction. Because they have these actin filaments, they can physically pull on the surrounding matrix, essentially contracting the wound. This helps to draw the edges of the wound closer together, significantly reducing the size of the defect over time. It's especially important in large open wounds.
Okay, so we've got this dense patch, mostly made of strong type I collagen. It's been stabilized, contracted by myofibroblasts. Is that the end of the story, or does the body keep fiddling with this scar?
Oh, it's definitely not the end. The scar continues to change and adapt for a long time, sometimes months or even years. This final phase is called remodeling. And the ultimate state of the scar really depends on a continuous balancing act between ongoing ECM synthesis, still influenced by factors like TGF-beta, and ECM degradation or breakdown.
So the body's still breaking down parts of the scar it just built. Why? And what does the breaking down?
It does. The breakdown is essential for reshaping the scar. Initially, the collagen might be laid down somewhat haphazardly. Remodeling allows it to be reorganized along lines of stress, making it stronger and more functional, structurally speaking. The main demolition crew responsible for this breakdown are those matrix metalloproteinases, MMPs again.
Ah, the MMPs are back. What exactly do they do?
They're a whole family of enzymes, and they're specialized. Some MMPs, called collagenases, specifically chop up the fibrillar collagens like type I. Others, like gelinases, work on different types of collagen and matrix components. Stromalysins tackle a broader range of ECM molecules. Together, they can carefully degrade the existing matrix, allowing it to be replaced and reshaped.
But wait, if these MMPs are so good at chewing up collagen, how does the body stop them from just destroying the entire scar? That sounds risky.
It would be very risky. This is where incredibly tight regulation comes in. There are two main levels of control. First, NMPs are usually produced and secreted as inactive precursors, called proenzymes or zymogens. They need to be activated locally, right where the remodeling is needed, often by other enzymes like plasmin.
So they're only switched on where needed. What's the second control?
The second, and perhaps even more critical control, is that their activity is very quickly and specifically blocked by another family of proteins called tissue inhibitors of metalloproteinases, or TIMPs.
TIMPs. So they're like the safety switch or the brakes for the MMPs.
Exactly. TIMPs bind tightly to active MMPs and shut them down. So the actual amount of ECM breakdown happening at any given time depends critically on the local balance, the ratio between active MMPs and available TIMPs.
So if you have more active MMPs than TIMPs, the matrix breaks down. If TIMPs dominate, synthesis wins.
Precisely. This constant push and pull, this dynamic equilibrium between synthesis, driven by TGF-in and fibroblasts, and degradation, mediated by MMPs and controlled by TIMPs, is what allows the scar to slowly remodel, gain strength, and mature over a long period. It's never quite as strong as the original tissue, but this remodeling process optimizes its structure as much as possible.
Okay, that detailed sequence really lays out the mechanics. Now let's connect it to what we see in real life. How does this play out, for instance, with a simple cut on the skin versus maybe a much larger wound?
Right, when we talk about skin wounds, we often classify the healing based on how much tissue is lost and whether the edges are close together. The ideal scenario is called healing by first intention, or primary union.
Like a clean surgical incision that's been stitched up.
Exactly. The edges are brought right together, approximated. There's minimal tissue loss, just a thin line of damage. In this case, repair is dominated by the epithelial cells regenerating quickly across that tiny gap. Inflammation is minimal and brief. You only need a tiny bit of granulation tissue, and the final scar is usually just a thin, neat line.
Okay, that's the best case. What about the opposite end? Healing by second intention or secondary union?
That's what happens when you have a much larger wound with significant tissue loss. Think of a large ulcer, a severe burn, or a big ragged laceration where the edges can't be pulled together neatly.
So the biological challenge is much greater.
Immensely greater. You start with a much larger blood clot and fibrin deposit filling the defect. There's usually way more debris and necrosis, leading to a much more intense and prolonged inflammatory response, partly because the wound is open to contamination for longer.
Which means you need a lot more granulation tissue to fill that huge gap.
A massive amount more, yes. And this is where that wound contraction by the myofibroblasts becomes really prominent and visually obvious. Those cells work hard to pull the edges of the large defect inwards.
How much can they actually shrink the wound?
It can be quite dramatic. In large skin wounds, healing by second intention, contraction can sometimes reduce the surface area of the defect down to just 5 or 10% of its original size over about 6 weeks. It's a crucial mechanism for closing large gaps that couldn't possibly be covered just by epithelial migration alone.
That's incredible. But let's talk about the strength of the final scar tissue again. You mentioned earlier it never gets back to 100%. Why is that, even after all that remodeling?
It's primarily because the architecture is different. Normal skin dermis has this complex, interwoven, almost basket weave pattern of type I collagen fibers, which gives it strength in all directions. Scar tissue, even after remodeling, tends to have collagen fibers that are more aligned in parallel bundles.
Which isn't as strong.
It's generally not as resilient to multidirectional forces. So while sutures might give you about 70% of normal strength right after surgery, the wound's intrinsic strength increases slowly as collagen is deposited and cross-linked. But even after 3 months or more of remodeling, it usually only reaches about 70% to 80% of the strength of the original uninjured skin, and it rarely gets significantly stronger after that point. It remains a point of relative weakness. #TAG-B. Factors that compromise tissue repair. Why scars fail.
Okay, so we've seen how complex and regulated this whole process is. It makes sense that things can go wrong. What are the major factors that can interfere with healing, making scars weaker or delaying the process?
From a clinical perspective, probably the single most important cause of delayed healing is infection. If bacteria colonize the wound, they perpetuate the inflammatory phase.
Keeps those M1 macrophages active.
Exactly. It prevents that crucial switch to the M2 repair phenotype. Chronic inflammation just leads to more tissue damage, more MMP activity, and prevents the fibroblasts from properly kicking into gear. Controlling infection is paramount for good healing.
Beyond local infection, what about systemic issues? Things going on in the rest of the body. Diabetes comes to mind immediately. Why is diabetes so bad for wound healing?
Diabetes is a major problem because it hits repair from so many angles. First, Many diabetics have underlying vascular disease, especially microvascular disease. This means poor blood flow to the wound area, limiting the delivery of oxygen, nutrients, and essential repair cells. Angiogenesis is often impaired.
Okay, poor plumbing. What
High
else?
blood sugar itself is toxic. It leads to the formation of advanced glycation end products, or AGs. These AGs can cross-link proteins abnormally, making tissue stiffer and interfering with normal ECM function and remodeling. They also impair immune cell function. On top of that, many diabetics develop neuropathy, nerve damage, especially in their feet.
Meaning they might not even feel an injury.
Right, they might get a blister or a small cut and not realize it until it's become a large infected ulcer. So you have poor blood flow, impaired cell function, and often delayed detection. It's really a perfect storm for chronic non-healing wounds.
What about nutrition? Does that play a big role?
A huge role, and it's sometimes overlooked. Remember, healing is an incredibly energy-intensive process involving massive protein synthesis. If a patient is malnourished, particularly deficient in protein, they simply don't have the building blocks to make collagen and other necessary matrix components.
Any specific vitamins?
Vitamin C is absolutely critical. It's required as a cofactor for enzymes that hydroxylate proline and lysine residues in collagen precursors. This hydroxylation step is essential for forming stable cross-links between collagen molecules. Without enough vitamin C, you get weak, unstable collagen, and healing essentially grinds to a halt. Think scurvy.
Right. And sometimes medical treatments themselves can interfere. You mentioned steroids, glucocorticoids earlier. How do they weaken scars?
Glucocorticoids are powerful anti-inflammatory drugs. Their main mechanism is suppressing the immune response, including inhibiting the production and effects of many cytokines. Critically, they inhibit TGF-air production.
Ah, hitting the master regulator of synthesis.
Exactly. By inhibiting TGFS, steroids reduce fibroblast proliferation and collagen synthesis. This intentionally dampens down scar formation, which can be useful therapeutically in some situations, like preventing excessive scarring in the eye. But the trade-off is that it generally results in a weaker scar with reduced tensile strength.
Makes sense. And then there are purely local factors too, right? Besides infection.
Definitely. Poor perfusion is a big one, whether it's due to clogged arteries, arteriosclerosis, or problems with veins, venous hypertension. Not enough oxygen gets to the tissue. Mechanical factors are also key. If a wound is under constant pressure or subject to twisting or shearing forces, it can literally pull apart, which we call dehiscence. And finally, the presence of foreign bodies like a splinter, dirt, or even suture material left too long can act like a persistent irritant, causing chronic inflammation and preventing healing, much like a low-grade infection. #TC. Abnormalities in scar formation, too much or too little.
So repair is all about balance. Finding that sweet spot between inflammation breakdown and synthesis building. What happens when that balance gets completely thrown off? Let's start with too little repair.
When the synthetic phase is deficient, or the inflammation just never resolves properly, you end up with chronic wounds. These are wounds that failed to proceed through the normal healing stages in an orderly and timely way. They get stuck.
Like those difficult ulcers you mentioned.
Exactly. Venous leg ulcers are very common, especially in older people. They're caused by chronic high pressure in the leg veins, leading to poor circulation, fluid leakage, and impaired oxygen delivery to the skin. Arterial ulcers, often on the feet or toes, are caused by atherosclerosis blocking blood flow. These tend to be very painful due to the ischemia.
And diabetic ulcers we discussed.
Right, driven by that combination of vascular disease, neuropathy, and metabolic issues. And pressure sores, or decubitus ulcers, are caused by prolonged compression cutting off blood supply to the skin and underlying tissue, leading to ischemic necrosis. All of these are examples where healing fails to launch or complete properly.
Okay, so that's deficient healing. What about the flip side? When the body goes overboard with the building phase and makes too much scar tissue.
That leads to excessive scarring, and we usually distinguish between a couple of main types based on how they behave. First, you have hypertrophic scars.
Hypertrophic, meaning overgrown.
Yes. These are raised, often red stars that result from too much collagen being deposited. They often contain a lot of those contractile myofibroblasts. But the key feature is that they stay within the boundaries of the original injury. They might be bulky, but they don't spread outwards. And importantly, they often tend to regress, at least partially, over several months.
Okay, so hypertrophic scars stay put and can shrink. What about keloids? They sound more serious.
They are generally more problematic. Keloids are fundamentally different. They represent a truly excessive, uncontrolled proliferation of collagen that grows beyond the original wound boundaries, invading the surrounding normal skin. They look like tumors of scar tissue almost.
And they don't shrink.
Rarely, if ever, do they regress spontaneously. They tend to be permanent and can be very difficult to treat, often recurring even after surgical removal. There seems to be a strong individual predisposition to forming keloids, and they are significantly more common in people with darker skin, particularly those of African descent. It suggests a fundamental, perhaps genetic, dysregulation in that TGF pathway or the MMP-TIMP balance that just doesn't shut off properly.
Wow. And what about that term proud flesh? Is that related?
Proud flesh is the common term for exuberant granulation.
Really?
This is when you get excessive formation of granulation tissue, that pink vascular stuff that actually bulges up above the level of the surrounding skin.
It's too much of a good thing.
Exactly. While granulation tissue is necessary, when there's too much of it forming this mound, it physically blocks the epithelial cells from migrating across the surface to close the wound. So paradoxically, this overgrowth of early repair tissue actually prevents the final step of reepithelialization.
One more abnormality, contractures.
Right. Contractures are basically an exaggeration of that normal wound contraction process mediated by myofibroblasts. While some contraction is needed, especially for large wounds, if it becomes excessive, it can cause severe deformities and limit mobility. This is particularly problematic over joints, like elbows, knees, or fingers, and on the palms or soles. We see devastating contractures after severe extensive burns, for example, which can permanently fuse joints or distort features. Hashtag defibrosis in parenchymal organs. The medical burden.
Okay, let's bring this back inside the body now. We talked about fibrosis being the term for excessive collagen in organs. This isn't just a microscopic curiosity, it's a massive cause of disease, right?
A huge global health burden, absolutely. When fibrosis occurs in vital organs, what we call parenchymal organs, it's often the result of chronic, unrelenting injury or inflammation. This could be from persistent infections like hepatitis C in the liver, autoimmune diseases, chronic exposure to toxins, or even metabolic stress. The end result is the same. Functional tissue gets progressively replaced by inert, dense collagen fibers.
And that leads directly to organ failure.
It does. The fibrosis disrupts the normal architecture and ultimately destroys the organ's ability to do its job.
Can we look at a couple of examples? Like liver cirrhosis, what's happening there functionally?
In cirrhosis, chronic liver injury from alcohol, viruses, fatty liver disease, whatever activates specific cells in the liver called hepatic stellate cells. These cells transform into myofibroblasts-like cells and start pumping out enormous amounts of collagen. This collagen forms dense bands, or septa, that break up the normal liver structure into isolated nodules of regenerating liver cells.
So it walls off the liver cells.
It does, and critically, it destroys the delicate vascular pathways, the sinusoids, where blood gets filtered and metabolic exchange happens. This leads to increased pressure in the portal vein system, portal hypertension, and ultimately catastrophic failure of all the liver's vital functions. Detoxification, protein synthesis, everything.
Okay, devastating. What about the lungs? You mentioned idiopathic pulmonary fibrosis, IPF.
IPF is another tragic example. Idiopathic means we often don't know the exact cause, but the lung seems to undergo cycles of repeated microscopic injury and abnormal repair. Again, fibroblasts become overactive, maybe driven by aberrant TGF signaling, and they relentlessly deposit collagen within the delicate air sacs, the alveoli, and the surrounding interstitium.
So the lung tissue itself gets replaced.
Yes. The normal, thin, elastic lung tissue responsible for gas exchange gets replaced by thick, stiff, fibrous tissue. The lung loses its compliance, its ability to expand, and the distance oxygen has to travel to get into the blood increases dramatically. It's like the lung turns into stiff, useless scar tissue. Patients become progressively short of breath, leading to respiratory failure.
So in both cases, the stability provided by the scar is completely useless because the organ can no longer perform its function.
Absolutely. The fibrosis might hold the organ together physically, but it kills its function. And because diseases like cirrhosis, IPF, end-stage kidney disease, and heart failure due to fibrosis cause such immense suffering and mortality worldwide, developing effective antifibrotic drugs is a huge focus of medical research right now.
Trying to dial back that excessive scarring.
Exactly. The goal isn't to stop repair altogether. We need that for wound healing. The challenge is to find ways to selectively target the pathological runaway fibrosis, maybe by modulating TGFS signaling more precisely or adjusting the MMP-TIMP balance without completely shutting down the necessary repair processes. It's a very tricky balancing act. Hashtag Tech4. Conclusion.
All right, let's try to pull this all together. We've taken quite a deep dive into scar formation. The core idea seems to be this paradox. When the body's best option, plan A, regeneration, is off the table.
Either because the cells are permanent, like neurons or heart muscle, or because the underlying scaffold, the ECM, is too damaged.
It switches immediately to plan B, building a patch.
A patch, the scar, that's fundamentally a compromise. It provides essential structural stability, which is often life-saving in the short term. And we've seen how this whole process hinges on that critical switcheroo by the macrophages, going from M1 demolition mode to M2 construction mode.
Right. And the whole construction project is orchestrated by that master regulator, TGF-β.
Absolutely. Driving synthesis, preventing breakdown, and shutting down inflammation. It's the key signal telling the fibroblast to build that collagen matrix.
And then the final shape and quality of that scar depend on the long-term remodeling.
Governed by that delicate tug-of-war between the MMPs, the breakdown crew, and their inhibitors, the TIMs. Get that balance wrong due to chronic disease like diabetes, persistent infection, or just bad luck.
And you end up with major problems, either wounds that won't heal, like chronic ulcers, or excessive scarring that causes disfigurement, like keloids, or even fatal organ failure from fibrosis.
Yeah, the big takeaway really is that scarring is this incredibly dynamic, tightly controlled process. But when that control is lost, the consequences can be severe.
Which leads us to a final, really fascinating question to leave you with. We've spent this whole time talking about how mammals, including us, go through this incredibly complex process just to create what is ultimately an imperfect, often functionally useless patch. But when you look elsewhere in nature, you see animals like salamanders or certain fish that can regenerate lost limbs, repair spinal cord damage, even regenerate parts of their heart almost perfectly.
Yeah.
No scar, just back to normal.
Mm-hmm.
So the provocative thought is, what's the fundamental difference? Is it something in their extracellular matrix? Is it the specific signals released right after injury? What allows them to bypass this whole elaborate patching process and just hit the regenerate button while we're usually stuck with the scar?
That is the multi-billion-dollar question in regenerative medicine, isn't it?
Mm-hmm.
If we could figure out how to unlock that kind of regenerative potential in mammals, in humans, well, that would change everything. Cracking that code is really the ultimate goal.
Yeah.